Yes.
Okay. So, hello, my name is Zuzanna Mirowska, and I'm a student from Medical University of Łódź in Poland. And today I would like to represent a case of Lyell syndrome treated with plasmapheresis. To begin with, I would like to briefly remind you what Lyell syndrome is. It's adverse reaction, cutaneous adverse severe reaction to drugs or infections. It's characterized by acute local manifestations and possible life-threatening systemic involvement. It results from delayed type 4 hypersensitivity to drugs or infections. Those drugs could be sulfa antibiotics, allopurinol, antiepileptics, or non-steroidal anti-inflammatory drugs. To better understand the clinical course, it typically progresses as shown in this diagram. After several days, up to 4 weeks of drug intake, the patient develops prodromal symptoms resembling influenza, such as headache, rhinitis, cough, muscle pain, headache. I said headache. Subsequently, atypical macular lesions appear on the skin, as in the picture beside. Over time, the skin lesions progress with the development of vesicles, bullae, skin necrosis, and positive Nikolsky sign, which is characteristic in this syndrome. It consists of epidermal sloughing after gentle rubbing or pressure of the affected skin. Also, mucosal surfaces are taken. You can see the necrosis, erosion, and also skin detachment. So beginning with our case, patient's case, his treatment history is really important. 3 weeks prior to admission, he had started therapy with 4 drugs: paroxetine, quetiapine, pregabalin, and lamotrigine, which was the most predictable causal drug. After several days, he developed flu-like symptoms and conjunctivitis. At that time, an infection was suspected, so he was treated with azithromycin, but the symptoms did not resolve. He developed skin lesions all over his body and perioral necrosis, as you can see in this image. So our patient, a 19-year-old male man, a 19-year-old man, was admitted in a critical general condition. His body was all covered with lesions, as you can see, and necrotic changes. On examination, he was fortunately hemodynamically and respiratorily stable. His Glasgow Coma Scale score was 15 points, which is maximum of the points, fortunately. Laboratory tests were performed, and apart from mild hypokalemia and hypocalcemia, there were no alarming findings. His inflammatory parameters were elevated. Procalcitonin was elevated, but did not suggest sepsis. CRP was really high, but it was due to a general inflammatory reaction from Lyell syndrome itself. Yes, not really alarming. Mild increased pH. He had slightly decreased albumins and not really high total protein. To assess the disease severity and mortality risk, the Scorton, our patient was evaluated with Scorton scale, and there is an error here because it says he has less than 10% of surface in lesions, but his whole body was in lesions, so he scored 1 point because the rest of criteria wasn't fulfilled, which makes his mortality risk the lowest, 3.2. So not that bad. Moving on to the treatment, The most important thing here was the discontinuation of the causative drugs. So for this time, they were all replaced for now with lorazepam. Gentle wound care and lesions hygiene was implemented, and his severe pain was treated with fentanyl, ketamine, buprenorphine, and paracetamol. He was treated with intravenous immunoglobulins, and most importantly, he underwent a total of 7 plasmapheresis sessions. There were several monitoring points that required constant attention. First of all, is sepsis that represents the major threat in patients with toxic epidermal necrolysis. Therefore, procalcitonin and CRP were constantly measured. To prevent hypovolemic shock, blood pressure and urine output were measured. Electrolyte were also assessed because there could be imbalances from the disease itself or plasmapheresis, especially eventual hypocalcemia. To prevent multi-organ dysfunction, because Lyell syndrome may lead to multi-organ dysfunction, blood pressure, lactates, arterial blood gases, GFR, and creatinine were constantly measured. If we want to follow those monitoring points, we can see them in the laboratory tests. As you can see, the mild hypokalemia was corrected, although calcium levels remained slightly decreased. Low creatinine here is attributed to lowered patient's muscle mass, but together with normal urea and GFR suggested the absence of renal failure. As you can see, inflammatory markers remained slightly increased in comparison to the norm, but CRP decreased overall over the days. There were no bacteria found in the microbiological swabs. Yes, it's not that. Those parameters weren't that bad. And also his albumin and total protein went up after 4 years. He was transferred from our department in a general good condition, and I'm pleased to show you the progression of skin treatment, skin healing in those following photographs. So this is admission day, then day 1. So changes all over his body and necrotic mouth. That's the third day. 6th day, 8th day, and the last day of discharge. As you can see, there is a big change. I would like to say a few words about the clinical approach to patients with toxic epidermal necrolysis. First of all, it is crucial to distinguish Lyell syndrome from another skin diseases. For example, measles and Kawasaki disease, similarly to Lyell, may present with prominent skin lesions and mucosal lesions. However, they lack in rapid disease progress and necrosis and Nikolsky sign, which are characteristic for Lyell. Second, there are some diseases that are only shown on mucosal surfaces, such as Fuchs syndrome. It is Lyell without skin involvement. It is Fuchs syndrome. Severe herp angina and mucous membrane pemphigoid, and you can see it on the pictures. When Lyell syndrome when we have a patient with Lyell syndrome, it is really important to treat him in intensive care unit or dedicated burn center. Second, the discontinuation of the causative drug is crucial. It is the most important step in the treatment. Doctors should be prepared for eventual intubation or urine catheterization because the mucosal changes may extend to respiratory or urinary tracts. Early placement of central venous access may also be considered and useful in the future. And also the recommendations say that we shouldn't use prophylactic antibiotic therapy. Even sepsis is the major threat in patients with Lyell syndrome. In recommendations, there are drugs for the first-line treatment, and the corticosteroids and cyclosporins are recommended as a first line. However, intravenous immunoglobulins and plasmapheresis are not routinely used, and they are categorized as therapy-free therapy according to ASFI guidelines, so not really used in this case. So why did we use plasmapheresis? In our hospital and collaborating centers, doctors value plasmapheresis for three main reasons. First of all, it enables the removal of toxic metabolites and cytokines, thereby targeting the disease process itself. Second, it is really useful when the first line therapy is ineffective or just can't be used. And it is used in severe cases like ours. And our case shows that the therapy was both effective and successful. So thank you for your attention, and if you have any questions, I will try my best to answer.
I have never had patients with such condition.
It's really rare.
And I would really freak out.
Yes, it looks horrible.
Definitely.
And if you have a child and he or she starts using medications and he or she develops flu-like symptoms, you would never think of this kind of result, right? Yes.
And then she gets some rash.
Yes. And conjunctivitis, so it also needs to be monitored because you could possibly end up being blind. But he is in general good condition. Our doctors are in contact with him. And yes.
So you never thought that as non-dermatologist deal with such condition?
Yes, because you could have systemic involvement. You could lose all of your electrolytes, hypovolemic shock. So some of the patients needs to be intubated, as I said. So that's why it's crucial to send him right away to intensive care unit.
For a rash.
Yes, for extensive rash. Yes.
Okay.
Yes. Right.
Thank you. Anyone else?
But he avoided intubation. This guy avoided intubation and stuff.
He was intubated.
No, he wasn't.
He was lucky.
Yes, because he was respiratorily stable. Yes, it's bad, but his parameters were good. He was in contact, and his Glasgow Coma Scale was the maximum. So our doctors thought there is no need yet to put him in sedation and so on.
Thank you.
Thank you.
So we would like to ask for some technical support there. And then I invite Maria to tell us something about redefining binaries in cardiothoracic